We'll call the meeting to order, and if you'll join me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Dee, if you could call the roll.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Wallace.
Present.
Director Danielson.
Present.
Director Eapen.
Present.
Great. We'll move on to our education session. And Nancy, could you introduce our speaker tonight?
Yes, I'd like to introduce Dr. David Lee. He joined UCSF as the co-medical director of our new UCSF Washington Cancer Center in January of this year. He has a clear desire to bring exceptional cancer care to the community setting. He is a fellowship-trained hematologist-oncologist. He received his medical degree from New York Medical College. He then completed a residency in internal medicine and a fellowship in hematology-oncology at UCLA Medical Center. Previous to joining UCSF, Dr. Lee was with the Palo Alto Medical Foundation for 8 years. With that, I'd like to turn the program over to Dr. Lee.
Thank you, Nancy, and thank you to the members of the board. Very happy and pleased to be here. Very excited about the progress we've made over time and our new partnership between UCSF as well as Washington Hospital. Tonight's talk is more of a big picture view about cancer treatment, where we've come from and where are we going in the future, and how will this partnership benefit both UCSF as well as Washington Hospital. If there are any questions regarding specific therapies, the talk wasn't really designed to talk about one particular type of medication, but I'd be happy to take any questions after the talk. Just as background, the National Cancer Institute estimates that last year alone, there were about 1.7 million new cases of cancer and close to 600,000 deaths attributable to cancer, making it the second most common cause of death in the U.S., eclipsed only by heart disease. Another way of looking at this is to say, if you look at all the men and women in the United States, about 40% of them will have cancer at some point in their lifetime. And while these are very scary statistics, thankfully, there has been some progress that's been made over time. From 2003 to 2012, it's estimated that on a year-to-year basis, there's been about a close to 2% reduction in deaths due to cancer. And while that may seem like a small number when you're just looking at 1 year in isolation, hopefully, much like compounding interest for our retirement accounts, that small amount will add up over time. And thankfully, because of this, we have an increased number of cancer survivors, which present their own challenge in terms of other kinds of health consequences related to their therapy. But we are just happy that we do have these increased number of survivors. There's clearly progress that's been made over time, but much work left to do. If we go back to 1971, at the State of the Union address, President Nixon addressed the country and for the first time made cancer a national agenda. And this was lambasted actually in the medical community as well as in the business community for many, many years. This was called the war on cancer. And if we look at cancer therapy from a narrow lens and wanting for there to be progress made over time, cures to be made over time, things were simply happening too slowly for most people, which is why there was so much criticism. As an example, one of the success stories is the treatment of Hodgkin's lymphoma. Hodgkin's lymphoma, for those who don't know, was at one point in time a deadly cancer, and it was particularly tragic because Hodgkin's lymphoma preferentially hits young people, generally in their late teens, 20s, and even up to their early 30s. The first time there was any effective therapy for Hodgkin's lymphoma was 1925, when radiation was used to treat a lymphomatous lesion, and you can see some regression of the lymphoma, though this was not curative. Then fast forward to 1943, Drs. Goodman and Gilman at Yale University, they made a very astute observation, when they looked at soldiers from World War I who were exposed to nitrogen mustard or mustard gas, they noticed that on top of all the bad effects that you could see in these people, these soldiers, if you actually check their blood, you can see that their blood counts were very low, particularly their immune cells or white blood cells. And they thought to themselves, maybe we could actually turn this agent of destruction into something useful. And because this was chemical warfare, they enrolled a patient. I don't think they really had a strong IRB protocol for this, but enrolled a patient in a trial with, quote, substance X, because they could not identify it as mustard gas because of legal implications. And they found some striking responses, though the individual who was treated was not cured, had a very quick relapse of his lymphoma. And then over the ensuing decades, up until about the mid-1960s, there was refinement in the knowledge of Hodgkin's lymphoma, as well as refinement in the radiation treatments. But then in 1966, the very first combination chemotherapy to treat Hodgkin's lymphoma, what we call the MOP regimen, was developed. And by 1970, just 4 years later, it was seen that this was a highly effective, highly curable now disease because of this combination of therapies. So from 1925 to 1970, about 45-year time lag, but we made progress. And by 1973, Bonadonna came up with a regimen called ABVD, which is still the most commonly used treatment for Hodgkin's lymphoma today. And it's not that we haven't made new drugs or new advances, but when you're talking about cure rates close to 90%, it's really hard to do better, especially because the treatments have been refined. We know how to treat people effectively with this and where people can tolerate the medications. So not only are they highly curable, it's a very well-tolerated therapy. When we're talking about chemotherapy, we're talking about a class of medicines that non-specifically kill rapidly dividing cells. And those could be cancerous cells, or they could be good, healthy, normal cells. And that's what gives us side effects. This doesn't project well, but that's okay. I think what we want to look at is just the trend lines. And this is looking at pediatric cancers starting from the 1970s at the very beginning of the left side of the slide, and then going to early 2000s. And you can see that the survival rates, which is on the y-axis, are all going up, with many now pediatric cancers with survivals and cure rates over 90%. So while there have been advances with chemotherapy treatments, there certainly have been limitations as well. This was one of the most depressing clinical trials ever conducted and reported on. This is from the New England Journal of Medicine in 2002, so not that long ago. And they had about 1,200 patients with advanced lung cancer that could not be treated with surgery. So they were randomized to get treated with one of 4 different types of chemotherapies. And when you look at these survival curves, the top one is looking at overall survival. What you can see is all the survival curves overlap, meaning no chemotherapy treatment was considered to be superior or inferior to any other one that was used in the treatment protocol. What you can also see was the median survival, or at the point where about half of the people in the trial are still alive and half of people have passed away, the median survival was only about 9 months long. And that's with chemotherapy. The bottom curve shows the time to progression, where the median time to progression was less than 5 months. So even if you had a response to the chemotherapy, it was very short-lived. Thankfully, while all this was going on with these chemotherapy trials, there was more and more advances in the understanding of cancer. Going back to 1971, Dr. Alfred Knudsen had first described the concept of what he called the 2-hit hypothesis, meaning cancers resulted because you had a normal cell that accumulated at least 2 different mutations that led to now what we call cancer. And what we realized as time went on is it's in most cancers not a single hit or 2 hits, but multiple hits. And this illustration represents at the very top normal colon cells. And then they develop a single mutation, and that mutation leads to a precancerous polyp. And then if another mutation occurs, then you have what's called a dysplastic polyp, which is even more precancerous. And then further down, if there are more mutations, then you develop actually colon cancer. And then from there, if you develop more mutations, these colon cancer cells now can break off from the colon and metastasize or spread to other parts of the body. And so as we understand carcinogenesis, or how cancers arrive, then we can also develop better treatments and as well as better strategies. So actually doing screening tests. Screening tests are designed to find a disease before they are deadly, and where we can actually treat a disease and impact the natural history. So in the case of colon cancer, you could do a colonoscopy or any other test that would find a cancer when it's precancerous. You could actually remove that precancerous polyp and prevent the cancer from even developing. That's great if we could convince people to do the screening tests. And even if we can convince them, the screening tests aren't always perfect. So we wanted to also figure out what are the specific mutations that occur. Are there common mutations that may occur in certain types of cancers? And if so, can we actually start to target it? And so in the 1990s to 2000s, then we started to call this era the era of targeted therapy. Though the concept of targeted therapy was not new, and this is just weird coincidence, this is also from 1971. The first targeted therapy to treat cancer, this is the first description of it. And they talked about this investigational drug that had anti-estrogenic effects, and it was tamoxifen. And by the late 1980s, tamoxifen was found to be a highly effective way of treating women with hormone receptor positive breast cancer, and can also be very well tolerated. As I was saying, by the 1990s to early 2000s, there was a much, much better understanding of different types of mutations that would be driving cancers, and then the development of drugs to actually target them. So there were advances in blood cancers like leukemias and lymphomas, as well as other types of solid tumor cancers. One thing I want to point out there is NSCLC is just abbreviation for non-small cell lung cancer. Remember that chemotherapy trial that showed a median survival of just about 9 to 10 months with chemotherapy? From 2002 to just about 2005, 2006, so just a few years later, there was an understanding that there's actually subsets of lung cancer, one subset being a mutation in a growth factor receptor called EGFR. And you would see these EGFR mutations particularly in non-smokers. And it was also observed epidemiologically that the greatest growth rate in lung cancer by then was in non-smokers. And this was one of the reasons why this was occurring. And so there were a handful of drugs that were developed and subsequently approved by the FDA. And with proper therapy, now the median overall survival for EGFR mutated non-small cell lung cancer is over 30 months. So tripling their survival in just about a decade. There was this huge race then to discover more and more driving mutations to develop what we call genetic or molecular profiling of cancers. This is what's called a heat map of leukemia cells. This is a heat map of breast cancer cells. And basically what they found is there are particular molecular signatures or genetic signatures that would distinguish one breast cancer different than another breast cancer. And so we would hear in the clinic and we would observe in the clinic, why is it that you would have two women with what looks like identical breast cancer treated identically, and one person does great and another one does terribly? Because even though there are certain pathologic features of the cancer that we can do on routine testing, if you actually delve down deeper and you look at their genetic profile, you realize that they're totally different cancers. And so while one therapy may work for one person, another therapy will have to be used to treat this second individual. By the mid to late 2000s, then we started to really realize that our concept of targeted therapy was somewhat limited. And I think part of the problem was expectation. By the early 2000s, there was this rush of all these new medicines, improvement in treatment, but we forgot that just like chemotherapy, any kind of therapy we use is going to have pros and cons, and there can be limitations. And so more recently, over the last decade, there's been this evolution of thinking, well, let's not abandon chemotherapy in patients who need it. Let's not abandon targeted therapies, but maybe we should use chemotherapy in some patients, targeted therapies in others, immunotherapy nowadays in other types of patients, and really this concept of precision medicine came about. And I think the easiest way to sum it up is to say, right treatment for the right patient. Back in 2015, in the State of the Union address, President Obama actually talked about precision medicine, and not just in the cancer perspective, but looking at this for all diseases. The idea of precision medicine, the idea of using genetic profiling, is not just something for scientific research. We utilize it every day in our clinic. So this is a report from November of 2015, also in the New England Journal of Medicine, looking at a test called Oncotype DX. And we utilize this all the time. I had a patient this morning that I recommended that we send our breast cancer specimen for Oncotype DX testing to see whether or not we should use chemotherapy after her surgery. And in this trial, they had over 10,000 women enrolled, and about 1,600 of them had what they called a low-risk score. And the trial was designed that if you had a low-risk score, these patients were not given chemotherapy, just hormonal therapy like drugs like tamoxifen. And that may seem intuitive, but the trial was designed so that the pathologic features that were in these patients were features where any reasonable oncologist would actually consider using chemotherapy. So it's basically saying, even though you think chemotherapy may help this person, we're not going to give chemotherapy because we think that the genetic profiling is so accurate in distinguishing that this is a good acting cancer. And this was fantastic. If you look at the recurrence rates within the breast, recurrence rates in other organs throughout the body, we're talking 99%. It's very difficult to get better than 99%, particularly when we're talking about cancer. That was breast cancer. There's genetic profiling for a whole host of cancers as well, including what people often call histologic agnostic, meaning it doesn't matter where the cancer is coming from in the body, you can send it for genetic profiling. So Foundation Medicine is one of the leading companies to do this. UCSF has actually developed its own genetic profiling test. And they did this not for profit reasons, but they did it because they found that with all of the various platforms that were available, that each of them had their own limitations. And particularly one of the limitations for most of them is that they'll check for what we call somatic mutations. Those are mutations that develop over the course of our life, but they don't actually look for germline mutations or mutations that can run in the family. And so that's really important to look at so you don't have to do separate testing. Especially nowadays, there are certain therapeutic drugs that we know will work if you have certain germline mutations. And they've developed now this whole, what they call molecular oncology infrastructure, where they have the UCSF 500 test. They will also utilize outside tests, these normal commercially available testing, look at this information, coordinate this with their own research, and try to figure out what is the best way to treat people, and are there certain algorithms that can be developed that would steer us in certain directions. The idea of a tumor board is a very old concept where you get a lot of different experts, surgeons, pathologists, radiologists, medical oncologists, radiation oncologists, put them in a room together, discuss difficult cases, and come up with a treatment recommendation. But there's also now what they call a molecular tumor board, where they would actually look at all this molecular profiling data as well as their normal pathologic features, and try to develop the best strategy for therapy. So the hope is with next generation DNA sequencing, we can define new cancer subtypes as well as new therapeutic implications, truly match individual aberrations with targeted therapies, or really not just thinking about this in a targeted fashion, but really more of a precision medicine fashion. We're going to need some time and some patience. Hopefully, it won't take the same amount of time that it took for Hodgkin's lymphoma. And actually, one of the things that's most challenging in oncology today is the overwhelming choice of treatments. Oftentimes, we have these lulls in medical therapy, and then we'll make these jumps where we have this advance in knowledge as well as advance in drugs. But over the last 5 to 10 years, the curve has been like this. And it seems like every other week there's a new drug that's being approved, which is great news for our patients. Certainly a challenge for us, though, to keep up with everything and make sure we are truly using the right drug for the right patient, not just jumping on the bandwagon because it's the latest, greatest drug. We need to keep advancing medical knowledge. There must be a dedication to research, and we need collaboration. And the collaborations can be small collaborations, the collaborations can be large-scale, multinational collaborations, but that's really the only way we're going to really make progress. We need to get the best minds together, and we need to share knowledge and share experience. The UCSF Washington Hospital partnership is still fairly young. This started back in January, so we've just had 5 months, and it's grown tremendously, and it's been, I think, quite beneficial for our patients and for the community. I think one of the attractions for me was the idea that we could not just treat my patients, but I could create a program, work with others in the creation of the program, where this can be a benefit to not just patients that come to my office, but other people in the community. So we're working hard with UCSF. We're just in meetings about developing clinical trials here at Washington Hospital, so patients no longer have to travel, whether it be to San Francisco or to Stanford and Palo Alto. They could actually be enrolled in these clinical trials right here in the community. We're working with UCSF to do what we call virtual tumor boards. So UCSF has tumor boards at least 2 a day, it seems like, every day of the week. And we're actually now presenting patients that we see here up to UCSF through video conferencing, and we'll have some of the doctors here in the community that are taking care of the patients at the same time. We invite them to come along, and they participate and give their perspective on what they see with their patients. And that's been very nice to develop that. We're working about what other types of technologies we can upgrade here to make sure that the patients that are treated at Washington Hospital truly get cutting-edge care. There have been a lot of people both here as well as UCSF that have put in a lot of hours and time and thoughts into this, and I just wanted to make sure I give them their credit. If there are any questions, I'm available.
Pat, Bernie, Tim?
Thank you.
Thank you very much, Dr. Lee, for that beautiful lecture on the progress of care of our cancer patients. We'll now move on to consideration of the minutes of May 10th, 15th, 22nd, 24th, and 25th. If I could have a motion?
So moved.
Thank you.
Second.
We have a second from Director Danielson. Dee, could you?
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eapen.
Great. The minutes are passed. Thank you. Do we have any oral communications, Dee? Any cards?
No, we do not.
Okay, thank you. We have written communications. Dr. Choi, credentialing action items.
Thank you. Here to present the credentials action items. The new appointments are as follows: Dr. Johanne Gray, Internal Medicine; Dr. Ronald Matus, Internal Medicine; Dr. Doris Nguyen, Internal Medicine; Sung Peg, Neonatology and Pediatrics; Barry Towers, Perfusionist; and Alana Shane, pathology surgery. Under temporary privileges, there's Benjamin G., MD, for radiology, interventional radiology, Johann Gray, MD, for internal medicine, and Barry Towers as a perfusionist. Under reappointments, we have the following. Dr. Carl Jeffrey Carlson for cardiology, Dr. Aruna Chakravorty for endocrinology, Dr. Gerline Diol for physician assistant, Dr. Craig Johnson, OBGYN, Dr. Gopala Kolaru, cardiology, Dr. Christina Lee, internal medicine, Dr. Jasbir Multani, neurosurgery, Dr. Noga Ravid, pediatric, Dr. Dipti Saxena, family medicine, Dr. Manish Singhai, internal medicine, Dr. Rajesh Singhai, urology, Dr. Dennis Townsend, family medicine, and Dr. Sunil Upender, radiology. Under transfer and staff category, from provisional to active, we have Dr. John Siu, as well as him in the same category of completion of proctoring and advancement staff category. Extension of proctorship and provisional category, we have Dr. Sharang Chang, Dr. Amy Mogul, Dr. Lin Nang, Dr. Bijal Patel, and Bernadita Rowe, nurse practitioner. Under new privilege requests, we have Dr. Shilpa Chetty with maternal fetal medicine and OBGYN, and PA Christopher Wilkins, physician assistant. Under deleting privilege requests, we have Dr. Carlson with cardiology and Dr. Craig Johnson with OBGYN. We have Dr. Deepta Saxena with family medicine and Dr. Rajesh Shanghai with urology. Withdrawal of applications include Jennifer Ariola, perfusionists, and Monica Richardson, gynecology. And resignations include Keith Jeffries, PA, and Steve Prado, perfusionist. That's the end of my report. Thank you.
Thank you very much, Dr. Choi. I would entertain a motion for approval of the credentialing action items as presented by Dr. Choi.
Move for approval as presented.
Thank you. Do we have a second?
Second.
Second from Dr. Stewart. Dee, if you could call the roll.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eben.
Thank you. Credentialing action items are passed. You have those done, Dr. Choi. Thank you. Debbie, Service League.
Good evening, everyone. But this month, first of all, I would like to thank the hospital for recognizing our volunteers last month at the Volunteer Appreciation Luncheon. You were Miss Nancy, but extend thank yous to Kimberly for speaking on your behalf. Dr. Nicholson as well, for your eloquent words of wisdom that you passed on. I think it's important for the volunteers to be able to hear from you, from the staff. You contribute a lot, and they need to know that. But it's nice that we get to go there and do nothing. We just show up for the party. And it was very lovely, and we all appreciate the thought and time that went in by everyone preparing for that. We've distributed our newsletter. It was a little bit longer than normal because we were in that transition. We're doing it quarterly now because it is a big undertaking. And so we'll see what the next president does, but this president at this time is doing it quarterly, and it seems to be working out fine. My editor is expecting her third baby any time, so it works out well for her as well. So, and I can't thank her enough for all the time and energy she puts into help putting that together. The other thing is we are very busy with recruiting, orientation information sessions. It's that time of year where we get a lot of students coming in, and they're staffing either in the gift shop or in the lobby, so training's going on. But we also recognize that we need to really reach out and to our adult community to have adult volunteers be part of the volunteer system. They're the ones, especially during the day, that are there to be able to volunteer, and that's something that we really, really could use in the hospital in all areas. Let's see, what else did we have going on this month? The social today. We recognized, we had an ice cream kind of beachy themed social today for the volunteers, recognizing their hours of service. And a thank you goes out to our social committee for the volunteers, Jeannie and Gail and Cherie and Nancy and June. They all work very tirelessly to make this special for our volunteers. And we had approximately of about 30 to 35 people that attended that. Our volunteer hours this last month, in adults, we had 1,754, college 275, juniors 364, spiritual care 262, trainees 125, giving us a total of 2,807 hours of volunteer service for last month. And that pretty much sums it up.
Thank you so much, Debbie. It was
Thank
really
you.
nice to be there at the luncheon.
Thank you.
I'm glad you enjoyed it.
Yes, I did.
Great. Okay, we'll move on to our medical staff report. Dr. Choi.
So I'd like to report that we're at a very high number right now. Our grand total is 597 with 348 active members. Or 46, sorry.
So do you have a prediction for 600?
We're going to top 600 in the next month.
We'll see you in July. Right, we'll see that in July.
We'll see that in July.
What a way to start off the new year. Thank you very much. Nancy, hospital calendar.
We'll start with the video first. Thank you.
Past health promotions and outreach events. On Thursday, May 11th, the Washington Hospital Green Team hosted an Energizer station, which was co-sponsored by the City of Fremont as part of the National Bike to Work Day. The team greeted cyclists during the 7 to 9 a.m. commute at the Fremont BART station with goodie bags, fresh fruit, water, and pastries. More than 100 cyclists participated. Also on Thursday, May 11th, Washington Hospital hosted Celebration of Life. This event featured stories of survival and hope for cancer survivors and their families. In addition, Dr. Jeff Lynn, gynecologic oncologist, presented strategies to help prevent reoccurrence of cancer. Dr. Victoria Leapart, gynecologist, provided the welcome address and moderated the event. The event is sponsored by Washington Hospital, Hers Breast Cancer Foundation, Palo Alto Medical Foundation, and the American Cancer Society. More than 60 people attended. On Friday, May 12th, Washington Hospital participated in the Four Seasons of Health Senior Health Fair. This event featured more than 100 vendors providing information for seniors. Washington Hospital offered bone density screenings for osteoporosis, and Washington Township Medical Foundation provided heart health information. 47 bone density screenings were provided. More than 1,000 people attended the event. Washington Hospital was also a sponsor for this event. On Thursday, May 18th, Lucy Hernandez, Community Outreach Project Manager, provided bone density screenings for osteoporosis at the Dominican Sisters of Mission San Jose Health Fair. 23 bone density screenings were provided. More than 60 people attended. Also on Thursday, May 18th, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Nutrition Myths Debunked: Truth Behind Common Diet Beliefs. 13 people attended. On Thursday, May 25th, Dr. Sunil Dewan, dermatologist, screened community members to potentially detect skin cancer before their symptoms occurred. This screening assisted in the detection of cancer at an early stage. 15 people were screened. Of those, 6 were recommended for further evaluation. Immediately following the skin cancer screening on May 25th, Dr. Sunil Dewan, dermatologist, presented The Sun, the Beauty or the Beast. 18 people attended. On Thursday, June 1st, as part of the Diabetes Matter series, Mary Sun, registered dietitian, presented Diabetes, Is There an App for That? 15 people attended. Also on Thursday, June 1st, as part of the Speakers Bureau, Christy Caracappa, Health Insurance Information Service Coordinator, provided an overview of the Health Insurance Information Service Program and other community services available at Washington Hospital and surrounding areas to the Breast Cancer Support Group. 11 people attended. On Thursday, June 8th, Vida Reed, RN, presented Stop Diabetes Before It Starts. 39 people attended. Upcoming health promotions and community outreach events. On Thursday, June 15th from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Improving Mobility, Flexibility, and Strength Through Body and Posture Awareness. On Friday, June 30th from 1 to 3 p.m., Maggie Gooding, registered dietitian, will present Fun Fresh Summer Cooking Demonstration. The 2017 Central Park Summer Concert Series kicks off on Thursday, July 6th. Washington Hospital is a major presenting sponsor. This 5-week concert series is free and open to the public and will be held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Washington Hospital will be providing health information and health screenings during this 5-week concert series. On Saturday, July 15th from 10 a.m. to 1 p.m., Washington Hospital will host a peripheral vascular disease screening event. This free screening includes a Doppler study of circulation in the legs and an interpretation of results. This event is co-sponsored by Fremont Bank Foundation. Pre-registration health questionnaire is required. Call 1-800-963-7070 to schedule your appointment. The Washington Hospital Healthcare Foundation Report. On Saturday, October 14th, the Washington Hospital Healthcare Foundation will host the 31st Annual Top Hat Dinner Dance. This year's gala will be chaired by Debbie Jackson, President of the Washington Hospital Service League, Dr. William Degoni, General Surgeon, Washington Township Medical Foundation, Medical Director of the Women's Center, and Gary Sharland, Executive Vice President of Masonic Homes. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the support for the Radiation Oncology Center, which offers oncology patients access to leading-edge treatment planning and delivery. The funds will be used to help underwrite the purchase of a new linear accelerator, a device most commonly used for radiation treatment for patients with cancer. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the Foundation at 510-791-3428. During the month of May, Washington Hospital Healthcare Foundation received 2 community gifts. Local Girl Scout Troop 33812 raised funds to purchase new books and a rolling cart for the patients in pediatrics. The Brownies and Girl Scouts delivering the book cart is the first of this type donation to our unit. It will allow our pediatric patients and their siblings the opportunity to enjoy reading. This is a great diversion. The mobility of the cart allows us to bring books to our patients if they are unable to come to the playroom, said Carmen Williams, RN, Senior Director for Maternal Child Health. Woolly Warmth delivered a large collection of hand-knitted items for pediatric patients. Woolly Warmth is a group of volunteers who provide handmade, knitted, and crocheted warm clothing to the families of newborns to keep their little ones cozy, comfortable, and healthy. The trustees of the foundation thank these groups for contributing gifts that benefit the patients of Washington Hospital. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended Indo-Americans for Better Communities Charity Ball on May 13th, the One Child Annual Fundraiser on June 2nd, and the Bay Area Women Against Rape Annual Gala on June 9th. Washington Hospital Employee Association, W.H.E.A. On Monday, May 22nd, W.H.E.A organized a blood drive with the American Red Cross. The American Red Cross registered 28 donors and collected 23 units of blood. W.H.E.A's efforts help boost the community blood supply to ensure patients have the life-saving blood they need. Washington on Wheels, W.O.W. Mobile Health Clinic. During the month of May, the Washington on Wheels Mobile Health Clinic, W.O.W., continued to serve community members at the Fremont Senior Center, Fremont Family Resource Center, and the Ruggieri Senior Center in Union City. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of May was 46. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include employment, about WHHS, programs and services, and volunteers. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a news feed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78 InHealth captured new programming, including 2 health and wellness programs titled Early Detection and Prevention of Female Cancers and The Sun, Beauty or the Beast, and a Diabetes Matters program called Insulin, Why I May Need It. In addition, InHealth aired Washington Hospital's special event on the Federal Health Policy Outlook, the April Citizens Bond Oversight Committee meeting, and the May Board of Directors meeting. Awards and recognitions. At the 45th anniversary dinner hosted by Bay Area Women Against Rape on June 9th, Washington Hospital Healthcare System was awarded the Community Partnership Award. In presenting the award, the Honorable Fiona Ma, member of the California State Board of Equalization, thanked Washington Hospital for providing office space to W.H.E.A to serve sexual assault victims in the Tri-City area, and for staffing sexual assault response team nurses around the clock in the emergency department. Washington Township Healthcare District Board members Pat Danielson and Dr. Bernard Stewart received the award and thanked W.H.E.A for their valuable partnership. Additional events and announcements. On Tuesday, May 16th, Washington Hospital hosted its annual Volunteer Recognition Luncheon. Washington Hospital honors, thanks, and celebrates all of the volunteers that help to support the healthcare system, including volunteer chaplains, Washington Hospital Employee Association Board volunteers, Mended Heart volunteers, Hospital Foundation volunteers, and Washington Service League volunteers. Washington Hospital volunteers are made up of women and men of all ages, including professional and retired adults, as well as college and high school age students who volunteer their time to help our patients and their families and to support hospital staff, physicians, and the overall healthcare system. More than 125 volunteers attended. On Sunday, May 21st, Alice Geno celebrated her 50th birthday with her father and siblings at the place of her birth, Washington Hospital. She is one of 11 Geno children, all of whom were raised in Fremont. Food and Nutrition Services, Maternal Child Health Services, and Community Relations departments work together to provide a true welcome, lunch in the cafe, a gift presented by nurses, and a visit to the Rose Garden, where their late mother's name is memorialized as a Washington Hospital volunteer. 50 years ago, Mr. Geno picked up his baby daughter in a new 1967 VW bus. To commemorate the occasion, one brother arranged to have a beautiful 1967 VW bus waiting to take them home. It was an honor for the hospital staff to be part of this special celebration with a family that is truly representative of the Washington Hospital community. On Wednesday, May 24th, Washington Hospital hosted a Rose Garden Remembrance event. This event provided an opportunity for the hospital community to remember employees, physicians, volunteers, and board members who have passed away while serving Washington Hospital. Miriam D. Christina, Washington Hospital staff, and Joan Warrener, volunteer, were remembered during this event. Father Jeff Finley, palliative care coordinator, provided non-denominational reflections. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070. And please follow us on Facebook, Twitter, and Instagram.
It's now my pleasure to announce the June employees of the month. We had an event here in May, which I'll get into in a minute, but it affected every employee in the house. And we had 2 employees that, at great inconvenience to themselves, stood up and made sure everybody would be taken care of. And these are our 2 employees of the month. Their co-workers combined resources to write an essay about the two of them, and I am going to read it in its entirety this evening because I think it expresses exactly how their co-workers feel about them. In an unusual recognition ceremony, 2 employees were honored as Employee of the Month for June. Senior Payroll Clerk Gloria Bonilla and Payroll Clerk Susie Arias recently defined the word teamwork as they worked together to successfully avoid a disaster that would have impacted every member of the hospital employee workforce. On Tuesday, May 23rd, our ADP payroll system was unexpectedly unavailable. This was a Tuesday in payroll week. Normally on that day, all payroll data is entered by our clerks as the first step in ensuring everyone is paid correctly and on time. But the ADP system was down, and I might add, there was no information about when it was coming back up. Both Gloria and Susie went on standby, and while she was cooking dinner for her family, Gloria received a message that the system was back up. She returned to work and stayed until 9:30 p.m., getting her part completed and ready for Susie, who came in 3 hours early the next morning, catching the 4:30 a.m. train from Tracy. Susie then completed her part of the task, and in the end, there was no delay in the payroll distribution, and only a few employees realized there had been an issue. Chief Financial Officer Chris Henry noted that this is only one example of what these 2 employees do for our staff members every day. They quietly make sure that each and every employee's compensation is calculated accurately and is delivered on time. Their commitment to customer service is beyond compare, and we are lucky to have them here at Washington Hospital. Gloria Bonilla has been part of the Washington Hospital family since 2004, when she began as a staffing clerk. Less than 2 years later, she became a payroll clerk and was promoted to senior payroll clerk in April of 2016. Gloria's respect and admiration for Washington Hospital is apparent. She says, quote, "This is a great organization. My job means that I interact with many employees, and I like that. It feels like a big family," unquote. Big family is something Gloria knows well. She's one of 8 children, the only girl, all of whom were raised in Fremont. 6 of her brothers still live in Fremont, as do her parents. One day, Gloria was puzzled when a coworker who lives near her parents asked if they have a lot of parties. "No, what do you mean?" she asked. Gloria laughed when she realized the woman was talking about Sunday dinners at her parents' home. "That's just our immediate family, enjoying my mom's cooking." Gloria and her husband Roy have 2 sons, Rudy and Jacob. While Jacob is her movie-going pal, Rudy's interests have recently brought a new member to the Bonilla family. Rudy loves horses, and his mare, La Munesa, recently gave birth to a baby girl, Flor de Mayo. Beautiful colt. Absolutely gorgeous. This is Gloria's 2nd time as Employee of the Month, an honor bestowed on very few. I had the feeling that Susie was going to get the award. When they called us into the break room, I stopped to put on lip gloss in case I was in a photo with her, she laughs. When Chris said my name, it took me a minute to realize what he was saying. Gloria becomes more serious when talking about Susie Arias. Susie has only been here a year, but she has contributed so much in that year. She is a great fit to our department and our organization. We both know that at Washington Hospital, we live the patient-first ethic. Even though we have no direct patient contact, Susie and I put the needs of the employees first, and that enables them to focus on our patients. Susie Arias has been working in payroll for various organizations for more than 30 years. Payroll is my passion, she says. I like the structure, the deadlines, the customer service element. It is one of the few areas in a company where you get to meet and help most staff members. Though she worked for other organizations, when the opportunity to be part of the Washington Hospital healthcare system family, she happily took it. At Washington Hospital, the patient care ethic means that everyone works together for the good of the patient. Whether you have direct patient contact, or work in payroll, you are contributing towards that. I know that every employee depends on getting paid the right amount and on time. Gloria and I do whatever it takes to make that happen. Susie commutes from Tracy. Unlike many commuters, she enjoys the ride because the hospital offers a shuttle service from the train station. Susie takes the ACE train every day. I listen to music, I read, or I get to know people, she says, and the shuttle drops me off at the front door. You can't beat that. Another type of ride that Susie enjoys is road trips with her husband, Eugenio. They get on the freeway in California and ride it as far as they can. We took Highway 10 to San Diego and then across the country all the way to Florida. Another time we took Highway 80 north and turned east through Utah and Iowa, most of the time on two-lane road through farmland. When not on the road, Susie spends time with her two sons, Robert and Michael, and her heartbeat, her 4 grandchildren. They spend time in the park, and often Susie indulges her 6-year-old granddaughter with her favorite pastime, shopping. When asked if she was surprised when they announced her name as Employee of the Month, she replied, "I thought they were going to have to call a code blue." Susie notes the amazing support she's received this past year from her entire team, including the Director of Accounting, Dave Tapia. Sharing the award with Gloria added to its meaning. Gloria and I are a team. We share the same goals and commitment. I am honored and humbled to share this award with her. So there are your 2 Employees of the Month. And personally, I couldn't appreciate their efforts more. It was a bad day. And there was no information about when the system was going back up. And it was a big concern. And we were also completely beyond the point of being able to influence any outcome at ADP. It was up to them. And they were being very tight-lipped about what was going on. So it was very hard to know what was coming. There was one other thing that I wanted to talk about briefly. There's been a lot of talk about a fight nationally against opioid addiction. And we've done a lot of discussing here at Washington Hospital the idea of having a pain management program. There was discussion about funding the Office of National Drug Control Policy. Their budget at one time was $388 million. I think that's their current budget. The budget proposed by the president would cut that budget by 95%. And the reason why I want to mention this as something that the residents of the district and the leadership of the hospital should be discussing is that in 2015, more than 25,000 people in the United States died from overdosing on opioids like fentanyl, oxycodone, and hydrocodone. More than twice as many as a decade earlier, according to the Centers for Disease Control and Prevention in Atlanta. The drugs either derived from opium or synthetic analogs of these narcotics now kill more Americans than homicide and are approaching traffic accidents as a cause of death. Middle-aged white men suffer disproportionately from opioid abuse, and the states with the highest overdose tolls are Ohio, Kentucky, New Hampshire, and West Virginia. The drug industry has spent millions of dollars on promotional activities and materials that falsely deny or trivialize the risk of these opioids, while overstating the benefits of using them for chronic pain. The state of Ohio is now suing Purdue Pharma, Teva Pharmaceutical Industries, Johnson & Johnson, Endo Pharmaceuticals, and Allergan. Purdue is the maker of OxyContin, which is a time-released opioid. Ohio's lawsuit seeks to recover money that the state had spent on the drugs themselves through programs like Medicaid and on addiction treatment. States took a similar approach in suing the tobacco industries of the 1990s, which eventually led to settlements worth more than $200 billion. So the attorneys that represented people suing the tobacco industries have now retooled themselves and are positioning themselves to sue Big Pharma. The state of California last week filed suit in a similar kind of lawsuit. I think you're going to see a great deal around this in the news. It is, quite apart from the massive settlements people expect to recoup, a very serious issue that on a local level we're going to have to pay attention to, get information out to the public so they understand what the risks are, and advance a pain management program that is well-centered in good medicine. I think it's a major issue when it rises to the level of rivaling homicides and car accidents. And it's time for the district to pay attention and provide education to the community. I think it's a pretty serious issue.
It's going to remain a serious issue for decades to come, but I was heartened to see that the FDA actually has started to take action. I believe they gave notice to Indo Pharmaceuticals recently that they're going to withdraw approval of one of their agents because it does not, at least in their labeling, does not accurately represent the risk versus benefit of that particular agent. So I think there's a lot more to be done in this problem, and I think the biggest hurdle we have to overcome is educate. These meds are not always the best answer.
Yeah.
They're potent and dangerous and need to be recognized as such.
They kill people.
Mm-hmm. And I think to develop a pain management system that can use all appropriate modalities to address patients' pain is going to be the best answer, because simply layering on opiate after opiate is not going to be the answer for the patients who we have who are in pain.
I see it as a very important issue in education, both for the general public as well as the members of the medical staff and the nursing staff, so that we can provide our patients with safe care. And I see that as becoming a major element of always having medication safety as an element of our institutional agenda. It's the first thing listed every year, and this is a new wrinkle in all of that. And I think that it's got to stay on the front burner.
I agree. Thank you, Nancy. Let's move on to our Lean Kaizen report. And Nancy, if you could
be happy to introduce
our
Michael.
speaker. Yes.
Michael Platzbacher has been with Washington Hospital for 24 years. He's a registered nurse with a Bachelor of Science degree in nursing and is a certified emergency nurse. He is the current manager of our emergency department.
Firstly, I'd like to thank the board for allowing me to come and speak about this topic. As Nancy said, I've been the manager for 24 years. Been in the ER for 24 years, been a manager for 11 years. So I really have borne witness to the changes, and they have been paradigmatic changes related to flow. And in the beginning, as you can imagine, the EDs, in the early 2000s, due to social, political, economic factors, the EDs across the country became the de facto source of care for large segments of the community population. So that was recognized in 2004, but at the beginning, there's two perspectives that are important. In the beginning, the focus was on the ED, and it really was ED flow. And to be truthful, Washington Hospital was very prescient, and because we established a committee in 2004 to actually look at that, and that was kind of unusual for non-academic centers. So we were on the right track. The second perspective is contextual one to think about patient flow. The ED flow was very myopic. It was just looking at us, and we were only one of the three three important factors there. You had the community, the input, you had throughput, which is us in the ED, but then you had the output, which is the inpatient sector. So the people, that was recognized, so the focus then shifted to the standards, and the focus shifted to system-wide, looking at all three of those aspects. Obviously, as a community hospital, we have little ability to impact the community sector, but we can do the inpatient and the ED focuses. So the purpose is to really improve hospital throughput and efficiency by a systematic evaluation and management of issues affecting patient flow. The second really important thing is it's aligned with a patient-centeredness philosophy, because if you sit in the emergency room for a long time, it is not value added for the patient in any means. It also has value for the system as well, because increased flow both in our sector and the inpatient sector is a patient satisfier. Quality outcomes are improved, and reimbursement is generally improved as well, because you can, contractually get better contracts. So the structure for us, focusing on the interdisciplinary focus includes physicians, nursing, leadership, bed control, environmental services, and the ancillary services. Because without lab and radiologists giving the physicians the results in a timely fashion, they can't make dispositions quickly. To go where we need to be, the vision needs to be, we need to have empirical data. So we are a very data-driven group. We have numerous reports both in the ED and in the inpatient sector, as well as lab and radiology. Even environmental services has empirical data to judge where they are and where we need to be. So the different strategies, we discussed different strategies in the monthly meeting, to decide where we want to focus and where our bigger issues are. Probably the biggest thing that happened to us, besides the system-wide input, was the infusion of the lean philosophy in the various workshop. It really gave us a synergy of effort. Everybody's on board throughout the organization, and it also, I can't speak for the inpatient sector, but I can speak for the ED. It really, we thought we knew all the answers in the ED, but we really could not see the forest for the trees. And so the lean philosophy, bringing different disparate groups in, non-clinicians even, to look at our issue, really helped us, because they came up with some novel ideas we just truly didn't see, because we thought we knew everything. So the emergency department of Washington Hospital has had a steady increase, as displayed by the graph. We saw 53,228 patients last year in 2016. Another important point to note is the impact of influenza in the first quarter of 2016. Now, 2017, I think the impact was even greater from the hospital perspective. The ED, the volumes weren't as high as they were in 2016. In February 2nd of 2016 and February 4th of 2016, we saw the most patients we've ever seen. It's easy to remember because it's 202 patients on the 2nd and 204 patients on the 4th. That's the highest we've ever been. However, we weren't admitting a lot of those patients at that time. So the system organizational-wide impact was a little less. This year, it was an imperfect storm. Our volume was a little less, but the influenza patients were sicker and they were getting admitted. It seemed to hit the patients that were a little bit older and had more comorbid illnesses. So that really, I think, impacted us the most. And during that time, we had our high census meetings. A lot of you, the audience was there, and were dramatic. It helped us dramatically, both on the inpatient and the ED, to give us the resources and support we needed. So the ED initiatives, these are broken out into ED and inpatient, but that implies that we're operating as silos, and we're not. We're operating in concert. So we developed a surge alert during high census, and we have some parameters, but our charge nurses can identify these parameters and initiate a surge alert. It's not something they need to go through any layer of management to do. And some of the other initiatives we did was our behavioral patient cohort. As one could easily imagine, the behavioral health patient cohort is underserved. A lot of times we are the safety net in the emergency room for that patient category. So we have a high behavioral patient category volume. So we did carved out a piece. Those of you who are familiar with the cast room, the previous room, we made it a safe place to house the behavioral patients. That affords them some privacy. And we also carved out the old quiet room is now for the adolescents, and it's a more conducive environment for them as well. Some of our workshops in Lean looked at issues issues with registration and fast track. And also we had a collaborative for West and ED lean workshop to look at how we get those patients from the ED to the floor. And then the inpatient looked at the second piece, how to get the patients that were going to be discharged in a timely fashion, identify them early, identify any gaps that they might have as far that would keep them from leaving home situations, home healthcare issues, and get those addressed so they can be discharged in a timely fashion. As I mentioned earlier, we can't do it without medical imaging and/or lab giving us the results both on the ED and the inpatient sector. So the results of the initiatives, despite our relatively high census, the length of stay for patients from the ED discharge has consistently been below the national benchmark. What really has significant ramifications for me, so the lead time, the length of time when they arrive in triage till we discharge them from the ED. And when we started the lean workshop in 2015, it was 2 hours and 8 minutes. At the quarter ending 12/16, just this past December, we made it down to 139. And December was a little misleading. The first 2 weeks of December were low census. The last 2 weeks were the beginning of that flu onslaught that we had. The behavioral health patients at Washington Hospital are transferred significantly faster than most hospitals, especially community hospitals. And the bed assignment to ED to inpatient transfer is a CMS metric. It's one of our quality metrics in the ED, but it's one we report to CMS that you can find on their website. We improved that by twofold. So the ED-specific initiative, as I mentioned, is a surge alert. And this is when we get a high volume of either walk-in or ambulance patients, and we really have no place to house those patients. So it occurs when all our staffed beds are occupied, and we have no other place to put patients that come in. So the charge nurses and the physicians on duty huddle. They involve the bed control. They involve the supervisor, myself, and but they don't need me to do it. They're empowered to do this themselves. And the ED docs, we see what they need to discharge the patients, either home or mid orders for the floor. We try to get them the information. We try to get transport and other services that we need. And one other aspect of the lean workshop, which really helped us, is sometimes we had a tendency to focus on the high level stuff. We need this lab result back. Why can't you make this decision quickly? But sometimes because of the lean workshop, it was actually the less complex, more banal things, like there weren't enough transporters. There was incongruity between the available transporters to take our patients up to the floor. So that was another focus of one of the workshops, to try to free up the transporters. And to make their job easier, we would make sure we had the ticket to ride, which they need to take patients upstairs, done in a timely fashion. And we assign if it's the influx of patients is the issue, we assign additional resources to triage patients quickly. As I mentioned earlier, the behavioral health accommodation, they need some privacy. In the ED, we traditionally focused on placing those patients where we could see them. We were more comfortable seeing them. We didn't want them to fall. But that really doesn't afford them any modicum of privacy. And that was also disturbing to some other segments of our population. The younger patients didn't have that cognitive and knowledge to understand that patient cohort. So we tried to identify those patients, put them back in the castrum, which is safe. It's been modified so that it has good egress for safety. It doesn't have anything hanging off the walls and things like that that create kind of an unsafe environment. We hired additional EMTs. Primarily, we used to focus on CNAs, but the EMTs have a higher skill set, a higher level. And I mentioned before the adolescent room. We have a carved out area where they can be kind of segregated from the rest of the ED to afford them a therapeutic environment. This is the lean workshop that we did in concert with W.H.E.A, and it was really eye-opening. In the beginning, in the ED, I've been there a long time, it really was a silo effect. It was us and the inpatient kind of operated on a different plane. Now we work together. The nurses realize that it's for the patients. To get the patients upstairs in a timely fashion is really patient-centered. And what we really tried to identify was the communication. The nurses on the floor couldn't communicate with the ED nurses. The nurse on the floor would be busy in an isolation room, couldn't answer the phone. By the time they called back, the ER nurse had got another sick patient. So we came up with the no delay handoff report, and it also utilized the robustness that's our electronic medical system. So we developed reports that gave the nurses on the floor the information they needed, gave the nurses in the ED an ability to put that information, and it's printed. We agree to a time where we can send the patient up, and once the bed is assigned by the charge nurse on the floor and bed control, they have a certain amount of time to get that patient up, and they understand that patient will come up at that time. Now, we still have the ability to communicate. We haven't lost the ability to do a face-to-face handoff if we need to. So there's some parameters built into there that, and the nurses on the floor can always call us. But it has been particularly effective. So the shift-to-shift handoff time is 20 minutes faster on the floor, and that's the nurses on the floor themselves. And patients had improved satisfaction with quietness because you don't have the nurses conversing as much. So this is another focus was trying to get a faster transfer time. So as you can tell, the transfer time is twice as fast as it was at the start of the workshop, and that is the median time from the bed assignment when the supervisor puts the bed in to the time we transfer them upstairs. The lean registration workshop really looked at the impact of the high census, a lot of people coming to queuing in the ED at the registration area. And this was a workshop that the registration folks did. And now we have a dedicated clerk at the registration window. And it also benefits us because the patients make contact with somebody. And it makes sure that with the electronic medical record, if you input the wrong patient, it has a lot of downstream effects that are hard to fix when you order things. So this makes sure the information is accurate. And once they make contact with people, they're more likely to be acknowledged, and they would like to stay. It also created a standard work for the registration process for the clerk, the nurses, and the EMT. The fast track workshop. This is another area where I think Washington Hospital was kind of in the vanguard of things. Nancy gave us the ability to use the old MRI unit, and we converted that to a fast track area, which was kind of unusual at the time. So this, as you know, the modular building took place of the MRI unit, so we had to move that fast track area somewhere. So we carved out the old waiting room and registration area, and really we tried to make sure that process was streamlined as possible. And we have a signaling system there, so the EMTs, the staff in the triage area know when a bed's available. It's not relegated on a call. They can tell when the bed's available, and it's the push-pull thing where the EMTs in the ED will pull the patients. They don't need to wait for any sort of other communication. And we really started to work on the standard work for rapid rooming. Directly rooming. So by the end of the workshop in September 2016, the arrival to a room time was half as when we started. And I'm pleased to announce that the end of March, which was our high census months, it has remained there for the fast track area. This talks about the left without being seen. It's one of the metrics that we report to CMS. And left without being seen is a bad thing because patients come in, they don't get their needs met, they leave without being seen. So we really try to do what we can to make sure those patients are triaged effectively, make contact with the nurse, and we rapidly room them when we can. And as you can tell, even the quarter end in 2016, the end of December was bad. Keep in mind, we were still down to 1.2 with the benchmark, and it's something we really would like to get down to 0. It's a little difficult to get down to 0 because we have patients, believe it or not, that come to Washington Hospital and they think they're a Kaiser. They've already registered. Technically, they're left without being seen, but we would strive to get it as low as we can. So the inpatient initiatives, the Lean Inpatient Discharge Workshop number 1, it's improved communication with the patient caregivers, and this is actually the nurses on the shift-to-shift communicating, the nurses on the shift communicating with the charge nurse and case management, and the physicians to try to get those patients that could go home, when they can go home, what do they need, and try to get that communication as timely as possible. And believe it or not, one of the identifying barriers that they identified was the family really sometimes had no knowledge when the patient was going to be discharged, so they didn't make the arrangements at home. So they tried to identify the patients that are going to leave, make sure the family members and support people are ready for the patients at that time. As of December 2016, as you can tell, the patient satisfaction on the Press Ganey scores improved by 18%. The continuation of that workshop number 2, really looked at the communication during the discharge piece that I alluded to. So the physicians put an earlier notification of discharge readiness in Epic, and that starts all the downstream processes. So as noted on the very bottom of the slide, there was a 31% increase in the notification of discharge readiness. So that process is working well. They had another workshop, which is the lean imaging flow workshop, and they were noticing a lot of times the patients would go down. They couldn't go down for their CT or their imaging on the floor, and we had this issue in the ED. Again, we were convinced in the ED that this was not our issue, it was radiology's issue. And again, we were wrong. It was a combination of factors, and we developed a lot of standard work. We do, when the patients come in, if they need a CT with contrast, the contrast agent is ionic. It's bad for your kidneys if you have any kidney disease because of diabetes. You really need a blood test to assess your kidney function. However, if we order that, the physician doesn't see the patient. The physician orders it. It can be 20, 30 minutes, even if lab is efficient, to get that result back. That patient's already waited an hour and a half. So what we did, as part of our workshop, we have standard work. Patients with abdominal pain, the nurses go ahead and get an iStat at that time. So we get that result back. So the physician has that result, radiology has that result. There's no delay in getting the patients to CT. And the decreased percentage of patients not ready for CT decreased by 55% because of that. And then the inpatient sector also looked at improving the lab turnaround times. They were looking at the stroke patients in particular. In the ED, I don't know if you've ever been in the ED for a stroke. It's actually, instead of a surge response, it's kind of a swarm response. Those patients actually come in the EMS. If they come in by EMS, they stay on the EMS gurney. They're seen by the stroke nurse, the ER physician, and phlebotomy is there. CT's been notified. They don't get off that gurney. They get their blood work that they need, and then they go straight to CT, so they hit the CT turnaround time, and we get their diagnoses, the process for diagnosis streamlined. They also had, for the inpatient in particular, they had a long wait times for the C. diff patients. C. diff is a type of disease we have to isolate, and they can't cohort them. So they lab worked with Beaker, which is the Epic version, so that they don't need to do the manual entry of the results. So as you can tell on the bottom, there's been a significant improvement even up until February 2017, and I know the lab volume was high, as was ours. So the next steps. We're not happy where we are. We have a vision to where we want to be, so we're going to continue to move forward. We're going to identify where the barriers are for the different the different metrics we have. We also want to continue working on our surge alert. The influenza testing, especially in the influenza season, really impacts us greatly. We're trying novel things like putting an ED physician at triage. We are also looking at rolling out the no delay handoff. 4 does it for all 3 shifts because they were part of our workshop, but we want to roll it out to the evening and night shift for the other units. We're also going to dive deeper into the delay during the day for CT imaging. Is it the ED? Is it imaging department? How can we fix it? And one significant factor that really occupies our mind is how we're going to transfer these processes to the new building. The new building, the old adage that you build it, they'll come. You know, we have 34 treatment spaces in the new building compared to 23 in the current ED. So we really need to work on our process for making sure that the inertia that we overcame with lean transfers to the new building. So I would like to thank, on behalf of the ED and inpatient, Nancy and Stephanie for giving us the guidance, wisdom, and support. And some of my colleagues here from the ER, so I'd like to represent them, acknowledge them. We have Brenda Brennan, Noemi Gonzalez, Betty Goodwin, and Dr. Lamb. So couldn't do it without them. So, any questions?
Any questions?
No, thank you.
Thank you very much, Michael. Obviously, hard work, good results. The real challenge will be the new building.
Yes, but it's exciting.
Yeah, but you've learned a lot of new skills to make that go easier. Thank you very much. Okay, construction report.
This evening, I'm sorry to report that Ed Van is home ill, and we have Robert Alfieri here this evening to stand in for him.
Good evening. So the construction update. Before I update you on our current project, I wanted to show how the campus has changed over the years. This is a shot of the campus back in 2007, right before the construction began. This is 2009. You can see that the central utility plant is starting right here. In 2010, we started the CJR while we were continuing with the central utility plant. In 2012, the ED modular, which Michael just mentioned a second ago. In 2012 as well, this is where we started to do the takedown of the old laundry to make way for the new building. This is in 2014. The Whitaker building, the Whitaker Annex, was demolished, and the beginning of the Whitaker building itself was being brought down. This shows the site completed, ready to completely demoed, and that was in 2014. In 2015, you could see that the parking structure has begun, along with the Morris Hyman Critical Care Pavilion. And the latest, I think I missed one. Oh, that's it. Well, that pretty much shows you the latest. Well, I'll show you a picture of the latest version at the end. Okay, so on to Morris Hyman Critical Care Pavilion update. This is the schedule. It shows that we're working on the exterior skin and the roofing still, site work, the loading dock prep is starting, along with the skin and the glazing or the windows. This is the basement. Excuse me, the ground floor. It shows how complete it is. We got the flooring down, the walls are up, painted, and they're starting to work on the ceiling grid. This is a temporary HVAC system, so we can maintain the temperature and humidity in the building while we're working. This shows the emergency department. This is the view from the waiting area. This is one of the nurses' stations in the emergency room, one of 5 nursing stations. This shows the CDU rooms, part of the actual ED, the casework going in. Again, the temporary HVAC system there. This is one of the elevator lobbies. We have established power to the building, so now they can start installing the elevators and having them operational. This is the second floor, the ICU CCU. This is the CCU side. This is the view from one of the nursing stations. You can see the extent of the ceiling grid going in. This is another view. This shows the station between the two rooms where a nursing staff can view two different patients at the same time. This is one of the third floor nursing stations, one of 5. And you can see that as we progressively go up the building, the extent of the construction is moving along. This is one of the waiting rooms on the 3rd floor. One of the corridors on the 3rd floor, again, the HVAC system is there. Now that the building is pretty much airtight, we want to maintain the humidity so there's no damage to the actual work that was already installed. This is the site work. This is the beginning of the work on the loading dock. So we're proceeding with the site work there. And this is the site view of itself. It shows that the panels and the glazing of the windows are about 90% complete. This is the north end facing the central utility plant. And here's our schedule. We're still on task for the June 2018 completion. Any questions?
No, but what I can see is that the site has grown so much, you're going to have to, the staff is going to need those little golf cart shuttles to run around from one end to the other end, so we don't wear them out. I suggested that years ago to an associate administrator, and he told me to go back to my room. He didn't want me to break anything.
No, there's no question, but this is going to be a significant adjustment. And that's why I think we need to allocate sufficient amount of time to practice our flows between the two buildings before we ever put patients in the new one. And that may take several months. I think we have to be very careful.
Robert, I really enjoyed the progression of the aerial photographs over the years. Now, if you could only show me the one from 2030.
We'll work on that.
Great, thank you.
Thank you.
I like that a lot better than if you showed me pictures of myself over
We have one, but it doesn't change.
I think he's got the right idea, though.
Yeah. Okay. All right, we'll go on to our quality report. Mary Bowron. Quality dashboard, quarter ending March.
Yep, good evening. This evening I'm going to be presenting the quality dashboard for quarter ending March 6th and March 2017, so January, February, and March. Before we get into core measure compliance, I wanted to give you a little bit of information about how this one with venous thromboembolism has changed since the last time I've brought it. Typically, when I bring it here, I show you a sample of about 110 cases. And CMS has required, as of January 2017, that we now have an electronic way of pulling out this data from the EMR and submitting it directly to them, called ECQMs, Electronic Core Measure Quality Measures Review. This is the first time that we've done it and brought it here forward like this. And to give you an example of the number of cases that are in this particular measure is about 1,863 versus the 110 that you used to see. So first time we've done the interface, and we are happy to report that the compliance for VTE on making sure that patients get preventative measures in throughout the hospital within the first 2 days of being admitted, and especially in ICU, has stayed fairly high. It's 96% to 99%. So you can see there was minimal change in that. We're still working on some interface changes in Epic and making sure that that things are built appropriately so that we can continue to improve this compliance rate. But we are looking at a much larger size. It is no longer a sample. There is not a benchmark on here because we do not have a benchmark yet, but I assume that that will be coming soon. So very similar to how it was when we did a manual abstraction as far as the results go. Moving on to stroke. Stroke is still a manually abstracted core measure, meaning that we have a human being in front of the computer looking all throughout the chart and looking for ways to find the documentation. So that has not changed. And for all of the measures, making sure that the patients get their discharge meds to prevent blood clots and their stroke education, and that they're assessed for rehab, that has all stayed within the national and state benchmarks. Going on to the infection prevention indicators, central line associated bloodstream infections, they were hovering around a little less than what was predicted by the CDC. We had 3 central line associated bloodstream infections, 1 ICU, 2 in med-surg. We have a new infection prevention program coordinator in our role in our program for infection control, and she's working closely with Dr. Martin. They're actually going to do a little mini RCA's root cause analysis to see if they can drill down even on these 3 cases and find some things that we can learn about, but what would have led to this patient developing a bloodstream infection after having a central line placed. Central catheter urinary tract infections did go up this quarter, and this is the second quarter in a row, more than we expected. And 9 counties is what you're seeing here. We looked at a couple things with this because 9, we thought was a pretty significant jump, and it relates to some things that we're going to try to make some changes around process improvement. One of the things that we've done with the process is we've implemented a nursing-driven protocol. And we had talked about this a little bit last quarter when I brought this forward. And I wanted to update you that the steps that we've made towards giving nurses the autonomy to remove a catheter when they can, when it no longer meets a medical indication to be in place, we've gotten further on. A lot more of the staff have been educated, and we're getting to the point now where we're going to go ahead and let this protocol go live. So what we foresee happening is that these catheters will be coming out sooner. and leading to a less catheter-associated urinary tract infections. The second part of what we're going to do for process improvement is go back and look at these cases. When we went back and looked at these cases, actually, we recognized that a couple of them didn't have a urine sample collected at the time of placement. And these patients tend to be, majority of these are over 75 years old. A couple of them came from skilled nursing facilities, a high-risk group to already have a urinary tract infection. So if you can collect the urine at the time of admission, right before you put in that catheter, then you'll recognize, the patient arrived with a urinary tract infection. And we want to make sure that that's happening 100% of the time, because it's something obviously that the physician still needs to be able to treat and look at, but it's not correct into saying that that medical device is what caused it. So those are the two process improvements that we're working on to bring that down, because we do understand that it's a significant increase. A C. difficile, as you know, this continues to sort of bounce around this quarter. We did also see an increase in that. This is a reflection of 21 hospital-associated C. diff infections. 18 of them were in med-surg, 3 of them were in critical care. Dr. Martin and the C. diff task force spent a lot of time talking about these 21 cases in our task force group. And what we found is that about 5 of these had come from a skilled nursing facility. 3 of the 5 actually have come from the same skilled nursing facility. And so Dr. Martin and I were having a discussion. We just really want to be able to start to work with it, because you have to work with outside the hospital to reduce C. diff. That is what we're hearing over and over from epidemiologists that we've consulted with, from CDC website. All this is, look at what's in your community. And if your C. diff rate is high in your community, you've got to go outside of your hospital and educate and work with them. So we want to start with this one skilled nursing facility that we use quite a bit and see if we can share with them some of the cleaning practices that we've learned here, look a little bit more close at their antimicrobial stewardship, things like that. In addition to that, we will continue to focus on our own interventions here related to cleaning, antimicrobial stewardship, and of course the infection prevention processes, which is really focusing on hand hygiene. The second piece that we noticed on doing a drill down on this was that 4 of these cases had been retested within less than 7 days, these patients. And so we want to make sure that if a patient comes in and we've tested them and they're positive for C. diff, it is not the recommendation that you retest them for cure within 7 days and look to see, okay, so I gave my flagyl, did this, now does the patient no longer have C. diff? That is not the standard and recommendation. It did happen a few times in January, and I think, the intentions were good intentions. We had a high census. Everybody thought, well, if they're not having C. diff anymore, maybe we can look at, getting them into a semi-private room and these sort of things. So we were trying to help patient flow, and it doesn't work out, because they usually test positive again. And when you submit that to the CDC, they count that as twice, even though it's the same patient 7 days apart. So testing is an issue that we are going to be working with physicians, lab, everybody's involved, nursing, everybody. The kind of specimen you collect needs to conform to the container. If it doesn't, it should not be tested. So we really want to look down further at that and see if we're rejecting stools, because in this quarter we actually only rejected 1 stool, which is low, and that's what made us look at the testing. So I think with making those process improvements, we're hoping we'll end up seeing a decrease in this. Hospital-acquired MRSA, we did not have any infections that led to the blood. This is good, far below the benchmark. V.R.E., we did have 1, putting us slightly above what our goal is. And this patient, we looked a lot into their history, and there was actually a physician who stated that they thought they had some memory of this patient having V.R.E. in the past. It's sort of an anecdotal story. We don't have any proof in the medical records, so I can't sit here and tell you that I know this patient had it, 2 years ago. It could have been in another hospital, whatever, but the patient was here for an extended period of time in critical care and unfortunately ended up having V.R.E. in their blood. Surgical site colon surgeries, again, we have been able to go, this is our 4th quarter now without any colon surgical site infections. Real good achievement for the surgical team and the people taking care of the patients afterwards. Same applies to abdominal hysterectomy. We do not have any, and that is also putting us at our fourth quarter in a row like that. nursing sensitive indicators, acquired pressure ulcers. So for this, we did see a slight increase. So out of the 148 patients that they were able to sample during CalNOC, which is just a direct observation, this is a point prevalence. Walk in the hospital one day, look and do direct observation of as many patients as you can and get a sort of snapshot on what's going on. And so out of the 148, they did find 3 pressure ulcers on those patients. So this reflects 3 out of the 148. They were stage 2 pressure ulcers, so the redness had developed and there could be an ulcer on there that's intact or even broken down. This is not a full-blown ulcer, otherwise known as bed sore, but there was some change in the patient's lower back and on their buttocks. And so we look at those cases and they look back and see what was going on with the turning and the documentation and things like that. So we'll continue to work on that. Inpatient falls with injury. This is below the benchmark. Out of the 14,259 patient days they looked at with this, there was 1 fall, and this patient did get a contusion on their floor, and that's why on their arm, and that's why you'll see the moderate injury here, because that does qualify as it per the CalNOC definition. Our Joint Commission National Patient Safety Goals came out really well this quarter. All direct observation that was done for handoff communication was witnessed and documented, putting us at 100%. Same with patient identification. There was an area in the hospital that did not document their procedure timeout. They went back, looked just to assure that it happened. It was right before the beginning of a cath procedure, and it just was not documented. What they're doing now, if that box is not ticked, they are actually going back individually to that staff member and letting them know that, you have got to do the documentation, because there are surveyors and outsiders who would perceive it as not happening, even though everybody in the group made it very clear that it did happen. So we want to continue to work on that. Hand hygiene staying really good here above the Joint Commission national benchmark, which is 90%. We're at 98.4% for hand hygiene. Readmission rates. Pneumonia sort of hovering right at the benchmark. In the past, our 30-day Medicare pneumonia readmission rate is 17.5, and CMS was expecting it to be closer to 17.1. So this is 10 patients who returned out of the 57 that were in that time period. With heart failure, we had 25 out of 71, putting us consistently, as you can see, we've consistently been above the benchmark. If there's one area that we need to focus on with readmissions, it is absolutely the heart failure patients, and we do recognize that. Of the 25 that came back, yes, it's 25 encounters admissions, but it's 19 patients who came back out of 71. Now, when you measure and you see what CMS, how they look at this, they look at it definitely from 25. But a couple of these were repeat visits from the same patients. So what we would like to do is work closely with our readmissions team and really drill down on those cases and see what can we do to help those patients that continue to come back. That's our first group. That's the focus we should have on those, making sure that, do these patients have an appointment before they leave? Do they have transportation to get to their appointment? Did they get their medications filled? All the basics that we need to really be looking at with them to make sure that we don't have to expose them to an acute care environment unless they actually need it by medical necessity. AMI was below the benchmark, 4 out of 30, and these 4 actually did not return with a cardiovascular issue. They actually returned with more pulmonary lung issues, but we are below the benchmark on that. Do you have any questions?
Any questions? So it looks like C. diff, Foley catheters, and CHF readmissions are what requires work.
You're dead on. Yes, I would say the same.
Go to it.
Yeah, thank you.
Thank you very much, Mary. All right, finance report, Chris Henry.
Good evening. Tonight we will be looking at the operational and financial results for Washington Hospital for April. We'll start with our operating indicators. Both average daily census and patient days were about 6.4% above the budget in April. Average daily census came in 10.4 above the budget at 173.6. And our patient days were 312 above the budget at 5,209. Admissions were 12 above budget. That's about 1.2% at 1,011. So that all adds up to a longer length of stay. Our average length of stay for the month was 5.19. We'd expected 4.90 for April. Outpatient observation equivalent days were 65 below the budget at 180. Looking at utilization statistics, case mix index was higher than expected at 1.592. We had budgeted for 1.566. That is the indication of the severity of the cases we saw during the month. Deliveries were 34 below the budget at 122. Again, we've been short a couple of OBs. We do have a couple new ones starting very shortly, so we hope to see those OB numbers come up. Surgical cases were 49 below the budget at 140. That includes our joint replacement cases that came in, 49 below budget at 378. That includes 140 joint replacement cases that were 6 below the budget. Neurosurgical cases were pretty close to budget at 27. We had expected 29. Our cardiac surgical cases were 3 below budget at 8. So really the bulk of that variance came from general surgery. General surgeries were 38 below the budget in April. Cath lab procedures for the month were pretty close to the budget at 379, just 3 below the budget. Our outpatient surgery visits for the month were 649 below budget at 6,728. 155 of those were related to the prenatal diagnostic clinic that we had expected to be open at this point. Robert promises me that'll be ready to go before the end of the month. We'll see. Everything seems to be going smoothly there. The rest of that variance came in the areas of X-ray, respiratory therapy, and cardiac rehab. Emergency room continued to be busy in April with 4,519 visits, 15 above the budget. Quick look at the cath lab activity. Cardiac activity seemed to drop off in April. Peripheral vascular stayed strong, followed by the usual suspects, non-vascular IR and neurointerventional radiology. Looking at productivity, our productive full-time equivalents for the month came in at 1,283.8, about almost 24 above the budget. Non-productive FTEs were 8.1 below budget at 180.8, giving us total FTEs about 15.7 above the budget at 1,464.6. However, our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in 0.3 below the budget at 6.24. So again, management's doing a good job of managing the staffing to the activity of the hospital. Moving into the financials, total patient revenue came in about $1.1 million above the budget at $177,390,000. Our contractuals actually starting to trend toward more normal level at still above budget at 76.73. We had budgeted for 76.2, but that's come down from well over 77% in the more recent months. So we end up with net operating revenue about 1.6% below budget at $41,864,000. Operating expenses for the month, however, came in $2.2 million below budget at $38,397,000. Big drivers there were benefits were about $950,000 of that variance. We did have lower health and welfare costs during the month. Pro fees came in about $380,000 below budget. Insurance, marketing, and software maintenance combined came in about $340,000 below budget. And then our provision for bad debt and charity was $616,000 below budget. The private pay percentage in our gross revenue was about 1.8%. We'd budgeted for 2%, so that made a big difference for us. So we ended the month with an operating bottom line a little over $1.5 million above budget at $3.467 million. Non-operating income for the month about $508,000 below budget at $1,173,000. Couple of new items here I want to draw your attention to. One is the amortization of intangible assets. Those are intangible assets that were related to the purchase of the Fremont Office Center. That's cash flow that has already occurred. It's the recognition of cash flow that has already occurred. We're going to be seeing that over the next 2 years, accounting rules being what they are, picked out some items that we have to amortize. The other non-operating net number you see there of $594,000 represents the bond issuance costs on the revenue bond we did in April. So we end the month with a total bottom line a little over $1 million above budget at $4,640,000. So pretty good performance financially for April. Looking at our Financial Accounting Standards Board presentation, which is how financial markets would potentially adjust our numbers to take a look at us. Operating bottom line stays the same at a little under $3.5 million. We pull out our tax revenue that provides for the support of our general obligation bond debt and our unrealized loss of about $275,000, unrealized gain of about $275,000 to come up with a total bottom line from a FASB perspective of just a little bit over $3 million, about $781,000 above budget. So pretty good looking numbers from both a FASB and GASB perspective. So are there any questions on April's performance?
No, thank you very much, Chris. Thank you for good numbers this year. Okay, Nancy.
So we'll go on to talk about May, and these
Yes.
are our preliminary operational reports. For May, our gross revenue for May was very close to budget at $175.9 million. And compared to May of a year ago, it came in 3.5% higher. Our inpatient gross revenue was $1.5 million below budget at $130.4 million. The outpatient gross revenue, on the other hand, though, came in $1.3 million above budget at $45.5 million. Major drivers of the unfavorable revenue variance: room and board revenue was below budget by $1.4 million. And that was driven by lower census in the intensive care unit, also in the special care nursery. Surgical volume was below budget by 14%, driving surgical services revenue down by $2.9 million. These unfavorable variances were offset by ancillary services revenue that came in above budget by $2.7 million, and that was driven by pharmacy revenue that was $1.7 million above budget. And this was a direct result of the higher utilization of our infusion center that has occurred as a direct result of W.H.E.A and Lee starting the cancer program here with us. It is a 71.6% increase in revenue. Cath lab procedures were above budget by 1.9%. That drove cath lab procedure revenue above budget by $858,000. In terms of key census statistics, our average length of stay was 4.62. That was lower than budget. The outpatient observation days were 66, or nearly 30% below budget. The average daily census of 164 was 2 in number above budget. The average daily census was 8.6 higher than May a year ago. The admissions of 1,090 patients were above budget by 61. They were higher by that same number than May of 2016. Patient days of 5,096 were above budget by 85. Patient days for the month were 405 higher than May a year ago. Surgical cases in May were below budget by 61. We had an unfavorable variance for surgical services revenue of 7.9%. They were 35 cases below what we experienced in May a year ago. Inpatient surgeries were 22 in number below budget. They came in at 308. Our outpatient surgeries were also 39 below budget at 68. General surgical cases were below budget by 64. Joint replacement surgeries were below budget by 3. Cardiac surgeries were below budget by 1. And these unfavorable variances were offset by neurosurgical cases that came in above budget by 7. In terms of our cath lab activity, procedures for May were 372, or 7 cases above budget. The inpatient cath lab procedures were above budget by 12. The outpatient cath lab procedures below budget by 5. Neuro IR procedures were above budget in the cath lab by 12. Non-vascular IR procedures were above budget by 8. Peripheral vascular procedures were below budget by 6. Cardiac procedures were below budget by 7. Deliveries for the month of May were of 156 were below budget by 14 deliveries. We were lower than May a year ago by 21 cases. Non-emergency outpatient visits numbered 7,217, and they came in below budget by 460. Infusion center visits were 121 above budget. And again, I've referenced Timmy and Lee's presence and the development of the oncology program driving that. These positive variances were offset by the prenatal diagnostic clinics failure to open on time, and that's 140 cases that were in the budget. We're hoping this clinic will open the end of this month, the beginning of July. The delays have occurred as a direct result of delays in permitting by the city. X-ray visits, short stay visits, and lab visits were 406 below budget. Emergency room visits were 218 above budget and higher than a year ago by 222. Our productivity indicators, FTEs were above budget by 45.7. We had 1,274.4. The non-productive FTEs were below budget by 46.4. Total FTEs of 1,410.4 came in below budget by 0.7. So the total FTEs per adjusted occupied bed of 6.38 came in 2.3% below the budget. Other operational statistics that you might be interested in: our outpatient surgery center had 508 cases in May. This was above the budget by 4 cases. The clinic visits for the month of 3,875 were below budget by 539. Payer mix, slightly unfavorable for the month of May. Government-sponsored patients' revenue made up 72% of total gross revenue. We had budgeted 71.1, so it's just a slight variance. HMO revenue was 2.9% of gross revenue. We had budgeted 3.5. PPO revenue was 23% of gross revenue, which was below the budget of 23.4. Private pay revenue was 2.1% of gross revenue compared to a budget of 2. Our key financial statistics include days cash on hand for May was 172, and note the climb. This is an increase of 13 days from last month. The days in accounts receivable were 57, which I think is a totally remarkable number, and Finance Division deserves recognition for this. There was $475,088 in charity care applications pending or approved in May. And this is a trend that I think it's important for the board to mark. That was almost down to nothing, and now it's beginning to climb again. And I think the uncertainty over the continued existence of exchanges and the participation of insurance companies in those exchanges is going to dramatically impact those numbers. And it's the kind of situation where we could get hit coming and going.
And likely will. Thank you very much, Chris. Thank you, Nancy. We have 7 action items tonight, and these will be presented by Dr. Eapen. Item A.
Mr. President, I move for the adoption of resolution number 1180, which is a memorandum of understanding between Washington Hospital and the United Healthcare Workers West Service Employee International, Local 250, SEIU U.H.E.A, a recognized majority representative under the terms of the Board Resolution 331A, effective June 14th, 2017.
Thank you. Do we have a second?
Second.
Second from Director Wallace. Nancy?
I'd like to tell the board that the membership ratified the contract on May 26th. Negotiations began on May 4th and completed on the 26th. That's probably the fastest that we have ever done it. The terms of the memorandum are 3 years, and the contract was negotiated with no reopeners. This agreement covers 510 employees as of May 22nd, 2017. Highlights of the key financial items include across the board increases July 1, 2017 of 1.5%, January 1st, 2018, 1.5%, July 1st, 2018, 1.5%, January 1st, 2019, 1.5%, July 1, 2019, 1.5%, and January 1st, 2020, 1.5%. The key contract additions included clarifications of per diem hours worked, clarification of ETO, ESL accruals, benefit enhancement for those making $60,000 or less per year. We had put it at $50,000 some time ago, and at my request, we moved it to $60,000 just simply because of the cost of housing. Many of the employees that work in the SEIU classifications have great difficulty affording living here, and I wanted to protect them for having to pay for their family members in our benefits program. So that was something I initiated. I want them to get a break if it matters, and I think it does. And we also did some market adjustments to ensure that all employees are being paid according to the market, because we were experiencing a situation where the market had gotten ahead of us, and we were having difficulty recruiting for some very important positions, and we have to be market competitive.
Good. Thank you. Thank you very much, Nancy. Any discussion? Okay. Dee, if you could call the roll.
Director Nicholson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Danielson?
Aye.
Director Eapen?
Aye.
Great. Motion passes. Item B.
Mr. President, I move for adoption of resolution number 1181, which provides for the continuing expenditure authority and authorizes the chief executive officer to make any and all appropriate expenditure necessary for continued operations of the Washington Township Healthcare District and the Washington Township Development Corporation.
Second.
Thank you. We have a motion and a second from Director Wallace. Nancy?
We had a very unusual constellation of events in the finance division where 3 key people were experiencing some family emergencies that were of a protracted nature and are still ongoing. And therefore, out of consideration for them, I agreed with Chris that we would postpone the budget until July. I think it's important to give these employees the opportunity to be with their families at this time.
Yeah, I would agree with that, and I would agree that it's very important to have as accurate a budget as we can do, and that does require the time and effort. So we do have an expected ETA in July.
Yes, it will
Okay.
be on the board's agenda for the July public meeting.
Great, thank you. Any other discussion? Okay, Dee, if you would call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Okay, motion passes. Item C.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of hardware for a total amount not to exceed $53,347.87.
Great. Do we have a
Second.
Second from Mr. Wallace. Nancy, copiers, lots of them.
Well, there are 4 of them that are going to be replaced.
All right.
There are lots of people that believe in the mythology that computers do away with paper.
That just
Not true in a
doubles and
healthcare system. Not even close. We have 4 high-volume areas using copiers that need to be replaced. So we'll be replacing the older and more problematic copiers, and this should help out a great deal.
Great, thank you. Any discussion? If not, Dee, please call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Great, the motion passes. Thank you. Item D, from copiers to chairs.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of 124 chairs for a total amount not to exceed $36,978.62.
Second.
We have a second from Mr. Wallace.
These are the self-same chairs that were present when I joined the staff here 33 years ago. I think it's time that they're replaced, and we're replacing these chairs in the cafeteria and in the physician's dining room, the physician's cafe lounge.
Great, that sounds good. Thank you. Any discussion? If not, Dee, call the roll, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Motion passes. Item E.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into necessary contracts and proceed with the purchase of 19 Philips MPSC devices for a total amount not to exceed $117,360.29.
Second.
We have a second from Director Wallace. Thank you. Nancy, monitors for
This
here
ma-
and there.
Yeah, these monitors are the first phase of a replacement schedule that we have planned. It will replace older and unsupported Welsh Allen devices, most of which were purchased in 1998, and as you can well imagine, they have been exceeded in the market by things that are much better. The new standard of Philips will tie into the EPIC electronic health record when we move into the Morris Hyman Critical Care Pavilion. So this is in anticipation of that. And the Philips monitor will become the new standard of care.
Thank you. Thank you. Any other discussion? If not, Dee, please call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Great. Motion passes. Item F.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of 10 Stryker air mattress pumps for a total amount not to exceed $25,838.
Second.
Second from Director Wallace. Nancy, Stryker pumps?
Well,
for air
it's
mattresses.
interesting because these have a direct relationship to the quality statistics that were reported a little bit earlier related to bed sores. And these units are used to protect patients, the Stryker air mattress pumps, who are in danger of developing decubitus wounds. This pump mattress combination is a much more cost-effective solution than renting specialty beds.
Sure.
So during the recent high census period, we had to rent additional pump mattresses, and these 10 pump mattresses will add to our inventory and allow us to provide for patient needs without having to rent specialty beds. These pumps were not included in this year's budget, and so there will be a trade-out of other items in the capital budget for this purchase.
Thank you very much, Nancy. Any discussion? If not, Dee, please call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eaton?
Aye.
Thank you. Motion passes. Item G.
Mr. President, in accordance with the district law policies and procedures, I move that the board approve the Community Needs Assessment 2017 Implementation Plan, and the board authorize the Chief Executive Officer to enter into the necessary agreements to conduct a post-legislation gap analysis in order to evaluate existing and new programs and services.
Second. We have a second from Director Wallace. Nancy, our Community Needs Assessment Implementation Plan.
Every 3 years, we participate with the Northern California Hospital Council in a community needs assessment that is conducted by zip code. And it identifies the major mortality and morbidity issues for the residents of Washington Township. The Affordable Care Act requires nonprofit hospitals to complete a community health needs assessment every 3 years and make it available to the public. As part of this requirement, the hospital has to adopt an implementation strategy to address the health needs identified in the report. I would like to add that although it became a requirement for us with the Affordable Care Act, district hospitals were exempt from this law for many years, and we opted to participate anyhow and have since the Hospital Council first began collecting this data. So this is a very general plan. More specific plans will be brought before the board to fill this out, but it is the beginning of that process.
Yeah, it's a comprehensive and thoughtful plan. I think it's a very good item, and clearly we learn a lot from doing it.
Yes, we do.
I presume we're going to be taking this plan and informing the community of this plan, both...
Oh, yes, we will.
Good. I'm glad to see that. So, any other discussion? If not, Dee, call the roll, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eaton?
Aye.
Great. That concludes our action items. Nancy, do we have need for a closed session?
Yes, we do.
Okay, so we're going to adjourn to a closed session at this time. We're going to reconvene to open session and announce that no reportable action was taken in the closed session, and there being no further business before this board tonight, this meeting is adjourned. Thank you.